Good afternoon, everyone, and welcome to Grand Rounds. My name is Tom Forden, and I'm the chair and organizer of Grand Rounds. And we have moved to a hybrid system for Grand Rounds. So the opportunity is to sit in the Gannicke Lecture Theatre where I'm stood now, and you can sit at home in your office or at home, or wherever you may be, and listen to it on Zoom. I'm here with Sonali, our speaker for the day in the Gannicke, and it's just us. So if you do fancy coming to listen to this live in the Gannicke Lecture Theatre, there's lots of space in this echoey room. So that doesn't matter. Hybrid is hybrid, and it's still. I'm looking forward to this talk, whether you're in person with us in the room, or whether you're in your own offices or elsewhere. Can I just ask you all to mute your microphones, please? I could name and shame, but I won't. But a couple of you have still got your microphones turned on. So if you could mute, please, just for the duration of the talk, that would be fantastic. And Sonali Tarafdar is one of the VR surgeons in Ninewells. And I've been pestering her for some time now to come and give a talk at Grand Rounds about the work that she does. She is one of the small number of VR surgeons here in Tayside, and also does a huge amount of global citizenship work, which I think she's going to talk about at the end of her talk today. But she's going to focus for the majority of the talk on diabetic retinopathy and the advances in treatment in the ophthalmological world about that. So Sonali, thanks very much for coming. And she's going to sneak in from the side here. And if I could just remind you, please do turn off your microphones so that we can hear Sonali through the rest of the talk. Thank you very much. And on we go.
Okay, good afternoon, everyone. My name is Sonali Tarafdar. I'm one of the ophthalmology consultants. And as Tom already said, I am here to talk about mainly diabetic retinopathy, because that topic actually resonates with everyone, all the medics, I think. But first, this is a picture or graphic representation given to us by one of our patients. And this is, to the patient, it looks like when they are having vitrectomy surgery under local anesthetic. I thought this is fascinating, isn't it? So moving on, my talk is diabetic retinopathy, which I believe is a perfect storm. And I have to acknowledge my colleague, Dr. John Ellis, who has helped me not only becoming a consultant here and mentoring me, but also with this talk. So thank you, John. So as I said, diabetic retinopathy is a perfect storm, especially in the advanced stages. So there are three components that is needed for a perfect storm: an warm air coming from one direction, and a cold air coming from another direction, and mixed with tropical moisture, and that creates a perfect storm. Diabetic retinopathy also has three components which creates this perfect storm of a disease. And at the end stage, it looks like the picture that is on the right side of your screen. And so the three components for perfect storm in diabetic retinopathy are dysglycemia, which is rapid normalization of blood sugar levels, comorbidities, which leads to, for the patients, to difficult to attend, poor attendance. And the third one is slightly falls on us, delivery of care, which is doing sufficient amount of treatment in the form of laser at the right time. So the first component is dysglycemia, rapid normalization. So you would think that getting the blood sugar down, really down, would be a good thing, but it's like you're avoiding one crash and falling in front of the other. So very rapid normalization of blood sugar always creates significant amount of retinopathy progression to mostly to proliferation. So on that note, I'm going to give you some examples. This is a patient who's 25-year-old female, type 1 diabetic. I want you to look at the timeline on this slide. And as you can see, over the years, she has very high level of blood sugar levels. This is the old style HbA1c. She has had various episodes of diabetic ketoacidosis, but February 2006, you see there is no diabetic retinopathy. Her vision's very good, 6/6 both eyes. Same in January in 2007, again no diabetic. In 2008, something happened. Penny dropped to her somehow, and she got really good control, HbA1c 7.9%. And what happens then? In 2008, she came with proliferative retinopathy, severe, and she had the laser on the same day, over to about 2,500 in each eye. She still continued to have florid retinopathy, and December 2008, she needed even farther laser, this time under general anesthetic, indirect laser to cover the whole eye. But look at her vision. She has gone to hand movement in the right eye and till 2060 in the other eye. So just to show you the pictures, this is the 2008 picture for her right eye. As you can see, it's a severe retinopathy. If you can see in the picture, there are new vessels on the discs, new vessels elsewhere. This is eye going down really badly. So she has some laser. You can see the laser treatment scars on the top, but when this proliferation actually starts, there is a term called angiofibrotic switch, when the CTGF, or connective tissue growth factor, takes over from VEGF, vascular endothelial growth factor, and then you start having these white bits, which are fibrotic membranes, which are strong and contractile membrane, and it pulls the retina off, causing tractional detachment. So even despite the laser treatment, she is now developing this fibrosis. Again, further laser treatment, further fibrosis contraction, and finally a big vitreous hemorrhage, and she can't see anything, and her vision is hand movement for that reason. So what do we do then? Is the last treatment of proliferative diabetic retinopathy is surgical, and that's vitrectomy. So she has a vitrectomy, and her vision from hand movement to 6/18, just after the vitrectomy surgery, carries on. As the time goes by, her vision keeps improving and keeps improving, and settling down to about 6/9 N5, which is almost normal vision. So are we all happy that that's a happy ending of this story? But don't forget, she has two eyes. So this is her left eye. And similar picture in 2008 again. Again, laser treatment, same story, fibrosis developing, same story for the laser, even more fibrosis. You can see this fibrotic membrane involving her macular and foveal area. Then again, goes for another vitrectomy surgery, and back to 6/12 vision, and keeps improving. And she's normal in that eye. So that was one which was a happy ending success story, but unfortunately not every diabetic patient goes through the same path. So what happens in these patients? Poor attendance is very common because of comorbidities. Patients have multiple organ involvement, they have multiple appointments, they can't attend appointments always. This is a story which is about that factor of a 27-year-old female. Again, if you look at the timeline, her diabetes control is poor. In the meantime, poor thing, she had pyelonephritis, long-term hospital admission, then diabetic nephropathy. I'm going to show this picture, which is a fluorescent angiogram of this patient that I'm talking about. So while we do sometimes have to fluorescent angiogram, and this fluorescent angiogram, what it is showing is that there is new vessel on the disc which is leaking at the disc. But the main important thing I want to bring your attention to is this area where you can't see any blood vessel. There is complete dropout of arteries here, and that's ischemia. In her right eye, our ischemic zone, which is foveolar vascular zone, is increased, which means there is no blood supply. She has ischemic damage due to diabetes, and she has very poor vision, which is irreversible. Unfortunately, once ischemia sets in, there is no treatment for that. So what does fluorescein tell us? And this is a story of a 45-year-old female patient, 31 years of diabetes, type 1, no wait. It's 31 years, 1 week, and 3 days. What does that tell you? That tells you the patient is really switched on. She knows by the day when she was diagnosed with diabetes. She's a psychiatrist. She, despite this well controlled, because diabetes also has an effect on time, as 31 years diabetes, she presents with vitreous hemorrhage in the left eye, which can be treated, but the right eye 6/6 vision. However, this right eye, just broadly speaking, generally looking, doesn't look that bad. There is a few dots and blots, hemorrhages, but maybe the fovea looks slightly abnormal. But if I show you the fluorescein, anyone can see what's going on there. There is a petaloid kind of fluorescent, hyperfluorescence, which means she has the macular edema in that right eye. We would not know that without the fluorescein angiogram. So the last and third factor is lasers, delivery of care. This is a few examples. This is a 41-year-old gentleman who was sent 2016 in our clinic, and at that time he had some laser in the right eye. Left eye was still not needing laser, and then he lost to follow-up, and 2021 he came in with this in his left eye with the fibrosis all around the arcades, and actually this was pulling on the macula. He had a surgery in the left eye, and that's settling now. Another person, again, laser in one eye and left eye not so much, has big vitreous hemorrhage. So that's the importance. I'm showing you the pictures because I want to say how important this laser treatment, timely laser treatment is. So now to know how much laser, when do we know is enough, too much or not enough? So the laser treatment came from the early treatment diabetic retinopathy study in 1980s, where they have done first station treatment, 177 millimeter square treatment for 900 burns. Now that was 500 micron burns. Full treatment needs 1200 to 1600. That was, we were told by ETDRS about that. So many of us has this misconception that 1200, 1600 is good enough. However, our newer machines delivery system, we have 200 micron size burns. What that means is that to cover the full retina, you need almost 10,000 burns. This is due to the cover of surface area of the retina along the burn size. There is a mathematical calculation. I'm not going to bore you with that. Anyway, so there has been publication in 1998. Claire Bailey found that almost 81% of our patients are actually undertreated with laser. They have not had 10,000 burns. That's it. So we clearly need to do some more laser. So this plot tells you why I am stressing on the treatment so much, because treated eyes, the progression of retinopathy, this curve shows, is much, much, much slower than the untreated one, which is in red. Now, this is one patient who presented in 4th of April, exactly 2021, 37-year-old male. He was referred to us since 2016, no show. Referred again 2018, again no show. He came into the April 2021. He had new vessels. I can point it out to you, this area. We offered next week laser treatment. Again, unfortunately, he couldn't make it. Then mid-April, 19th of April 2021, he attended our casualty department with this. This was a hemorrhage. This is called a pre-retinal hemorrhage. This is hemorrhage between vitreous and retinal surfaces. So this is what he had. We started planning for surgery, but by the time he got the surgery, if you look at his right eye, he already has had that angiofibrotic switch turned on. He is having now traction and tractional detachment with this fibrosis. This is what it looks like on a magnified view. So what we do this for him, then this is what we do for them. Just to show you almost an hour and a half surgery in a minute and a half. This is what we do. This is called vitrectomy, delamination, and endolaser. So you have to take out all the vitreous, then carefully cut and separate the fibrotic membranes from its attachment, because if you pull it, it's going to pull the retina along with it off. So, and then you gradually cut and take it off. Very soon you will see where these things are attached with a pick just under with the retina. You'll come to see that. That's there. You can see the little white spot. This is where you don't want to pull. I'll let you just have a look at that. We check with triamcinolone, which is used as a vitreous stain, then check everywhere, and then more laser and fill the eye with an air bubble because we do sutureless surgery. So that's just to give you an idea about what vitrectomy surgery looks like from our side. So why is this important? Why am I talking to the wider medical community and saying, all your diabetic patients, please send them or motivate them to come to us? Because it has been seen as the utility of life of vision compared to other major medical problems. So if you have a vision between 660 and 618, which is the top letter of the chart to the number 4, which is middle of the chart, if you have vision something like that, it's only moderately reduced, then your utility of life goes down to as bad as having regular dialysis, having a fractured hip, or a severe angina. So it has got significant effect on a person's life. So, and the most commonly performed ophthalmic procedure gains your utility life's value to 15 to 20%. What is the most commonly performed ophthalmic procedure? Cataract surgery, which is on versus approximately 8% of value gain and 800 various different intervention across medicine. So we actually, through a very small procedure, give people a lot more as value for money. That's what I'm trying to say. Which brings me nicely to the next part of my talk, which is my global citizenship work about cataract surgery. So what is the global burden of visual loss? About 1 billion people around the world has moderate to severe vision loss. And 94 million of those are due to cataract, which is a preventable disease. And the prevalence, unfortunately, is 4 times higher in lower and middle income countries than higher income countries. So we need to do something to help that, to make things equal. And I have been fortunate to be involved with 2 different charities called Fiona Donald Eye Fund and Fighting Blindness in Ethiopia group, and been involved with them for a few years, since 2012, and been there doing our cataract surgery. This is from a local newspaper publication just after our 2020 visit. We came back just before the lockdown started. It's really, really amazing going there doing this thing. It's really, I cannot express how it feels like in any words. Anyway, what do we do there? Quite very different things than what I do here every day. We don't have any sophisticated machines that I just shown you in my vitrectomy surgery, just have very basic instruments and your hands. As you can see, their cataracts are really white. You can see the pupil is really, really white. So they are blind. So this is a cataract surgery manual called a small incision cataract surgery, to which you make a small incision and take the cataract out manually, put a new lens in, and it's usually self-sealed, and that's there, the cataract coming out. That's the lens. Sorry, Tom. That's the new lens going in, and that will let this person see. And just a bit of a maneuver, cleaning up, and that's it. We do about 260, between 260 to 300 cases per visit. We operate there 5 to 6 days in a row. We operate about 50 to 60 patients in a day. And we are a team of usually 5 doctors and 5 nurses. And although we operate on 300, we usually see about 600 to 800 patients. Unfortunately, there are many other pathologies that come to us which we can't treat there. We would be able to treat if we were here, but we don't have the equipment to do that. Anyway, I'm very, very proud to be associated with this work. And this is our last visit. And this little boy was my youngest patient in my 2020 visit. He's very shy, but he's smiling. This is a post-op day. And that is all you need to do this. Thank you very much. I will take any questions from here.
Love that. Right, thanks very much, Sonali. Well, it's no secret that I've been the beneficiary of Sonali and John Ellis's amazing work over the last 15 years and lots in the last 12 months. So the quality of life utility stuff that you talk about, I know firsthand. When you can't see, your life comes to a stop. John Ellis, who did my cataract operations, will remember the day that I went from having a 6:30 vision with a cataract to suddenly having 6:5 vision. I was in tears, to be honest. The change that can make. So it's amazing work, absolutely incredible. And I was asleep for all my operations, thankfully. So I'm intrigued. Is the manual cataract operation, which seems quite sticky, is that done under LA or GA?
Local anesthetic.
Jeez Louise.
And including this boy, local anesthetic. I've operated until 8-year-old under local anesthetic. They're tough people, really tough.
Yeah, absolutely, absolutely. Now then, I need to just move us along a little bit and stop sharing the screen so I can see if anybody has any questions in the chat. So please, if you have any questions for Sonali, please put them in the chat just now. Or to be brave and turn your microphone on, and that would be great if you have any questions. So the diabetic case that you showed, the most recent one, the one from 2021. So he didn't turn up. You offered him appointments and he didn't turn up. I think it just demonstrates how really quickly this can progress. So do you think if he had turned up and had the laser, then this is completely avoidable, or?
It is avoidable if the laser done in timely manner. Yes, if when it starts to proliferate. So the theory is that people postulate that you first get the VEGF drive, which is a vascular endothelial growth factor, which produces the new vessels, and you then start doing the treatments, and then after that the CTGF switches on. Once the CTGF switches on, it creates that fibrosis and scar tissue. So nowadays there is people advocate that you do the laser treatment a bit early, as soon as you start seeing this. The various other factors also affect, like how good the control is, and if you're very ill, then it gets bad quickly, etc. But yes, preventable. What is preventable is we can do the laser treatment, and many of these can be prevented. Not 100%, I don't think, but yeah.
So I'm also intrigued about the number of blasts. so there was 1,600, I think, in that initial trial, and now you're talking about 10,000 overall. How long does it take? Is it 50 hertz, so it's 50 a second, and you're just counting up? Or?
So usually one session, it's also how much the patient can tolerate, because after a while it gets a bit sore. So you can, in a cooperative patient, you can possibly do about 3,000 in one session.
Right.
And in a not so tolerant patient, 1,500 you can do in one session. And for that reason, when we have to, the first patient I showed was John's patient. He had to do really 4,000 in one go, and he had to put the patient on the general anesthetic for doing that.
And that's extraocularly. So you do that through the pupil, but you can do this intraocularly as well, can't you?
That's what I did in the surgery that I showed. So that's called endo laser. So you can't get the probe inside the eye, but the laser treatment in general that we do is as a clinic procedure. You just sit on a slit lamp, you know the slit lamp.
Oh, I know the slit lamp.
And similar machine with the laser attached to it, and you deliver through that. You can also deliver with the headset, the indirect ophthalmoscope. And so you can deliver in any way. As long as you can see the back of the eye, you can deliver the laser treatment. You don't have to be inside the eye.
And one of the things that the people in the audience may not have appreciated is that some of the photos that you showed are with the fancy new machine that provides the really wide angle. So they're not the fund. If you're looking at that as a physician and thinking, crikey, I don't see that with my fundoscope. What am I missing? It is a different machine, isn't it? Maybe you tell us about the machine.
So the last few photos I've shown are Optos photo, which is a wide angle camera, shows you 220 degrees of the fundus, which is that camera has got special prisms and things to do that. Even when we look at the fundus with an indirect lens, you don't see that amount of area in one go. You have to kind of add up various different fields, and in your head you add up and see what you are seeing as a full. That camera is specialized. You never would be able to see it with an ophthalmoscope.
S.J. Hill, sorry, I have to use my varifocals to read this from a distance. How has the Optus changed your ability to manage diabetics?
Well, I know who S.J. Hill is.
Okay,
Sarah, well, I hoped it would have done better by now, but it hasn't so far, because we are still waiting for these cameras to be networked for me to virtualize the whole diabetic service, which I have a plan. I have got all pathway ready and everything, but I cannot solve the IT problem at this point, but we are on it. We will get this network, and then diabetes service will be a lot more streamlined. Patients will have virtual clinics with this photos and OCTs, and including another practitioner will review them. And just like our macular service, Sarah, which you do, I'm trying to move 80% of my diabetic service towards that form of delivery of care. Thank you.
So I presume with the Optus camera, you can pick up earlier disease. You can have those photos. You can look at the serial changes without having to remember what's going on, and that should lead to better care, better outcomes in the end. But you still have to get that patient in the door, which I think is one of your points in there. Is you can't get them into the appointment, you can't take the photo. Rupert says, sounds like a brilliantly rewarding branch of medicine. Well, that's I think that's absolutely right. Can
I add just a little question onto that?
Please go for it. Yeah.
I'm doing a ScotGem medical course, which is it's been focused in GP a lot. We've had a lot of that. I don't know whether I'll follow that avenue, but I just wonder whether things like cataract surgery has always sounded, it's a really cool thing, and it sounds brilliantly rewarding, like I said. But I just wonder whether it's strictly done by ophthalmologists, or if it's a sort of isolated skill that someone could learn in a different branch of medicine.
Well, Rupert, thank you. Yes, at the moment, it's solely done by the ophthalmologist. You have to have a 7-year ophthalmology training to do that. However, there are various people trying and basically floating the idea of developing nurse practitioners who develops this skill and have a training maybe 2 or 3 years, and then delivering that care. However, it's not done yet. Still, it's done by just ophthalmologists. Yes.
Thanks very much.
Okay, does anybody else have any questions or comments they'd like to make before we round up? And Rupert has been the perfect stooge to give me the segue into next week's talk, which is about ScotGem. So that's the Scottish Graduate Entry Medical School, which is run as a collaboration between St Andrews and Dundee, between Tayside and Fife. And we heard about 3 years ago, I think, from the ScotGem team about how the service was developed. They were developing the program. They were starting to have their first entrance into the program, and we heard about how the GP-based attachments were beginning. Now we're going to welcome the team back next week, who are going to tell us the fruits of their labour as the students have progressed through the years and are coming through towards graduation now. So looking forward to hearing from them to see what they've learned, what went well, mistakes that were made, changes that are coming in terms of ScotGem. So that's next week. I think they're doing that just on Zoom. I don't think they can make it, but I'll let you know in the email. There's nodding in the crowd there. So I will sign off and just thank Sonali for an amazing talk. I think eyes are fascinating. I think it's incredible the work that you do, and not just in Tayside, but across on a global scale. And I say this to we talk about this at home to my wife. Is if I was being born 50 years ago, I'd be blind by now, with all the eye problems that I've had, but because of the skill and dedication of the ophthalmologists here, that I can still see. So thank you from me, and thanks from all of us. So thanks very much for coming. Thanks for listening. Thanks for taking part, and we'll see you all next week. Thanks very much.
Thank you.